Good evening, colleagues, and a very warm welcome to this certification course for nurses. One of the main aims of Heart Failure Association has been education and upgradation of knowledge for consultants, for students, for DM residents, and for physicians, and also for nurses. And therefore, in every meeting that we have held, our annual conferences, training of nurses has been an integral part. We all need to upgrade our knowledge regardless of who you are, because times are changing, the knowledge is evolving very quickly. And so this certification course for heart failure nurses has been designed. We are thankful to the Trained Nurses Association of India for having partnered with us, and we look forward to a very fruitful collaboration and upgradation of knowledge for all of us. With that, may I invite Dr. Ibrahim Uman to say a few words and take this forward.
Thank you, sir. Few words about Heart Failure Association of India. It was actually the brainchild and the efforts of Dr. V.K. Chopra, and we have come a long way in the last more than a decade. And I think we used to have nurses training program, I think from 2015 or 16 onwards. And many meetings, we had even 3-day sessions. So it was very well attended. And there were 2 certification meetings. This is the second one. And all credit to Dr. Hari Krishnan, who is our academic brain of this organization. So a few words on my own, because like the nurses are very, very important. So this July 2025 JACC article, they looked at the in-hospital sudden death, and they looked at different kinds of hospitals, like academic hospitals, tertiary hospitals, super specialty hospitals, teaching hospitals. And they found that only thing which really reduced or prevented sudden death, their resuscitation, and successful discharge were nurses. No, this is not the number of consultants, it is not the number of transplants these people did, and it was nurses. And the JACC wrote an editorial on that, and JACC Deep Dive had a podcast on that particular thing, highlighting the importance of nurses. And of course, we know that heart failure clinics, when run by nurses, did much, much, much better than heart failure clinics run by cardiologists or physicians. And we, HFA, we are trying to do in similar vein, have heart failure clinics like where the key person is the heart failure nurse. And so the key thing is the training of the nurses. And we have done, Dr. Hari and his team has done a wonderful, wonderful job. And we will see in the next 3 modules. And we have tried to make it basic, of which Dr. Hari would discuss. But the highlight, what I wanted to highlight is that, like, it's not the size of the hospital, is not the number of consultants, it is the trained nurses that determine. That's a wonderful article. It's in JACC, July 2025. So with that, I request Dr. Hari to take over.
Thank you, Abraham. I think this is a very crucial and important initiative from the Heart Failure Association of India. We recognize the role played by the nurses in the management of heart failure. We know that guideline-directed medical therapy improves the outcomes. For example, in a 55-year-old man, if you give the therapy, it will increase his lifespan by around 6 years or more. So that is the importance. No therapy has so far shown that much benefit. So to implement that therapy correctly, I think nurses play a very crucial role. And training programs like this is very important to reach that goal. So with that in mind, Heart Failure Association of India initiated this program. This is the second of the program, and we are planning to have multiple programs in future, because we are considering this as a priority area for training the nurses. So we have planned this program for 3 days, 2 hours each, 2 weeks apart. And we have the cream of the heart failure faculty from all over India. Today, we will have the basics how to evaluate the patient. The next session will be on management of heart failure in hospital and up to discharge. And subsequently, we have the long-term follow-up, how to follow up the patient, the heart failure clinics, and rehabilitation, etc. So that I request everyone to attend the program. We will have the recorded version. In case you are not able to attend some part of the program, the recordings will be available. And since we have a huge number of registrations, we initially planned for 1,000, then it crossed 1,500. Now we have around 2,000 registrations. Now we have shifted from the Zoom platform to YouTube. So this is streamed in YouTube also. On the last day, we will have a evaluation session. We will have around 20 to 25 MCQs. You can attempt the questions, and you can attempt it multiple times. You can go through it the second time. Even if you don't cross the 80% mark in the first instance, you can do it the second time. You will definitely have. It is not to test the knowledge or the person. It is basically to increase the awareness and create and to instill some basic concepts in the minds of the nurses. So that is how the program is designed. So welcome to the program. I hope this will be helpful to the nurses. And this is the initial step in developing a heart failure nurse training program in India. So many of the Western countries have this heart failure nurses, and they are the key people in improving the outcomes of this patient. So with these words, I hand over the session to Dr. Abraham Uman, who will be taking over you to today's session. So once again, welcome TN Trained Nurses. I thank Trained Nurses Association of India for the support. They could not join today due to some technical reasons. Next session, they will be addressing the participants. So thanks once again, and welcome to the program.
Thank you, Dr. Hari. So now let's go to the nitty-gritties of the program. So the next session is the basics about heart failure. What is heart failure and types of heart failure? For that, I invite Dr. Uday Jadhav. Dr. Uday is one of the preeminent heart failure specialists from Mumbai, and excellent teacher, excellent communicator, and his greatness is simplifying things, because he makes very complex things very simple. And the next 20 minutes or so, Dr. Uday would be talking about what is heart failure and types of heart failure. Following that, we will have a discussion. And if there is any question from the audience, that also can be tackled at that time or later. So over to you, Dr. Uday.
Thank you, Dr. Abram, for those kind words. Thank you, Dr. Vijay Chopra and Dr. Hari Krishnan, for this opportunity and for bringing forth a very important value-added aspect to our Heart Failure Association of India, that's getting our colleagues, the nurses, associated with our program. So let me share my screen, and over the next 15 minutes, Let me put forth my viewpoints. Give me a second, please. Just to make sure, is the screen well visible? And I go ahead.
Yeah, it's visible. Please go ahead.
Thank you. Thank you very much. So here is what we are going to do today. Let's simplify heart failure and get to the basics and try and have a good understanding as we build up the entire module. So I'm going to start with a very simple aspect of the definition of heart failure, what exactly it means, how do we look at it in clinical practice as doctors, as nurses. So first and foremost, please understand this thing. This is the best part of any cardiovascular disease that I know of because it's a clinical diagnosis. It's not a pathological diagnosis. It's not a investigation based diagnosis. It's a clinical syndrome made of absolutely crucial symptoms, symptoms that decide that the patient is in heart failure. For example, the patient would have breathlessness, ankle swelling, and fatigue. These are three very important symptoms, right? Shortness of breath, edema of legs, and is fatigue. And when we examine the patients, um, they get translated into similar signs. The neck veins are prominent when you turn the patient's head on one side. The legs have edema, and there are, on clinical examination, crepitations at the lung bases, and there on oxygen saturation, you may find the change in the oxygen saturation. This is usually due to a structural heart disease and or a functional heart disease. And basically what it causes is, as the heart starts functioning lesser and lesser, the intracardiac pressures, which we measure on simple things like echocardiography, which follows my talk, will show that enhancement of the pressures, and therefore the cardiac output gets reduced. Remember, we talked about fatigue. In the initial part, these patients will complain of fatigue when they start exercising. Will start complaining of little shortness of breath when they start exercising. And as on time goes on, the symptoms becomes very prominent. Once we identify what would be the likely reason of this heart failure, then this is what commonly is talked about: systolic heart failure and diastolic heart failure. I'll touch base on these terms later, where it's related to the contractility function of the heart or the relaxation function of the heart. And there can be other reasons. For example, there can be diseases of the valves. In India, rheumatic valvular heart disease is one of the most common disease, even now in district places. Diseases of the endocardium, the pericardium, arrhythmias, all of them can contribute to heart failure. So we keep this in mind. Uh, this is something which is followed in all clinical textbooks by all resident doctors, by all specialists, cardiologists as well as heart failure specialists, and I'm very certain the nurses. This is called as the NYHA classes, the New York Heart Association classes. And we must remember these four classes. In the first class, class one, there is no limitation of physical activity, right? So whatever a patient is accustomed to, therefore it's important to ask the patient, what is your two things? What is his occupation? And what is his day-to-day activity? How much is his routine? Does he walk to the railway station? Does he climb up the stairs? Does he take a bus, go to the office? Whatever it is. A ordinary physical activity which he is accustomed to will have no problems. But then these activities, if they start causing a slight limitation of physical activity, including a shortness of breath, right, or a fatigue or a palpitation, is NYHA class 2. 3 is very marked. So these patients say, well, we are completely okay, but now we can't walk in the house, do the kitchen work, do the basics. And 4 are the patients who come to your ER departments feeling very short of breath. Now, why is this important? The NYHA class, as it goes from 1, 2, 3, 4, tells you that the cardiac function is progressively getting worse and worse, lesser and lesser. Even before any echo or any investigation pick up the diagnosis, is the symptoms which will be able to pick up. So the stages of heart failure, as you would know, are stage A, and that's important. So in the community, why are we paying attention as not just HFAI, but all of us, doctors, nurses, is identify patients with blood pressure, diabetes, obesity, metabolic syndrome, and say, look, these are the patients who are at a risk for a heart failure. And that's something which we need to target. B, after we jump from A, don't have any symptoms or signs of heart failure as on now, but have evidence of one of the following. What are they? These patients on clinical examination will have murmurs, abnormal heart sounds, on X-ray ECG have enlarged heart, on their echo examination will show abnormal patterns, and there are some blood tests which you are aware of, those cardiac biomarkers like tropi and the BNP, and they are elevated. So these patients are actually in the pre-heart failure. In the stage C, they become symptomatic. Now they have established whatever were those pre-risk factors and whatever were the pre-heart failure stage B have now become symptomatic. And in D are those patients who really require hospitalization. So I have put them all together here. This is the ACCHA A, B, C, D, at risk, pre-symptomatic, advanced. And so these are the patients who have other risk factors and then go on to become more symptomatic and have signs, and then go ahead and get into the stage 4. Now, there are also other terms which we use in heart failure because we are talking about classification. New onset of heart failure, de novo, newly diagnosed. They were not aware of it. They were not aware of it. Neither we have a documentation of it. Now that we diagnose, that's de novo. Some of these patients will then either resolve in symptoms, they get better with medication, so they get into a remission. Mind you, this is going to be extremely important when we discuss therapy. Just because patients are in remissions, they are not cured. They will get worse if the medications are stopped, lifestyles are not taken care of. So, very relevant that those patients be carefully looked at. Persistent have ongoing symptoms, ongoing signs, and limited functional capacity. And then there is worsening heart failure where patients will come back with worsening symptoms and their functional capacity drops. So, 4 categories. Before I go to EF, sometimes we use the term systolic and diastolic. Fair enough, simple to understand. Something related to contractility, something related to relaxation. And then you have low output and high output cardiac failure, right? So patients' cardiac output is lesser, they're more fatigue, more shortness of breath then. Or they may have actually a good cardiac function, but there are other reasons. Anemic patient, very common in this country. And therefore, the cardiac output is normal. But the oxygen consumption commensurate to the peripheral tissue supply is lesser, and therefore they become short of breath. So that's high output cardiac failure. So low and high. Then we talk about the EF, and based on the EF, there are these categories which now we accept all over the globe. So what are they? Heart failure with reduced ejection fraction, HFrEF less than 40. Heart failure with a mid-range, mildly reduced ejection fraction, 41 to 49%. But there are patients who have a reduced EF and actually get better. So those are with improved EF, HEF, IMP, EF. And then finally, this is the new category over the years that they have a good contractility. Relaxation function is less, EF is more than 50, and maybe spontaneously or on provoking, they will show all signs of heart failure. That's the preserved ejection fraction, right? HFrEF, mid-range HFrEF, improved EF, and HFpEF, and a normal. So the initial classification, see what can happen to the trajectories. Those who are less than 40, 40 to 50, and 50. Those who are less than 40 can either stay less than 40 for a period of time, or can get better more than 40, or in HFrEF, the less than 40 may stay less than, may actually worsen, go below 40 if you just give up the medicines, or they stay where they are, stable enough, or actually improve. And that's the promise. And HFpEF is where they can get worse if you don't identify quickly the diagnosis and treat them well in time, or they can deteriorate slightly, or they can stay where it is. I will want all my staff nurses and my colleague doctors to uh, uh, keep in mind one thing which I learned when I went for fellowship at King's Hospital in London, is that one of the cardiologists actually rebuked us, saying that please do not say in front of the patient that you have poor cardiac function. You have a bad heart failure. That poor and bad words, I think, should be removed. We just say there is an impairment of cardiac function. And I'm going to remove this poor and bad because the therapeutics, as you will learn in the next 3 modules, don't miss any of the modules, will teach you one thing. And we'll all learn from it. In today's date, therapies can make a great difference, irrespective of the severity of the heart failure. Now, once you diagnose, and I'm not going to tread into the other parts of ECG, echo, MR, CT, Dr. Shantan will take it. Just make a good clinical assessment and look at two things, the BNPs and the NT-proBNPs exceeding 125 picograms or 35 picograms. Natriuretic peptides, as they call, are great for ruling out. If they are normal, by and large, you are safe, they are not heart failures. If they are elevated, there could be reasons. And then you do all those other investigation and evaluate for the cause. In the initial and the serial evaluation, the first important thing are the vital signs. The pulse, remember what are the signs of heart failure, left-sided heart failure? So easy. Tachycardia, tachypnea, and low systolic blood pressure. Any patient who is short of breath, drops his BP, has a high heart rate, high low oxygen in the emergency department, that's the suspicion besides other differential diagnosis, right? So clinical history examination is important. Take a good family history in today's date. Ask them, any other members in the family, there is a genetic trend for it. Once you do that, also look at some disorders which may not be cardiac. For example, anemia or a hyperthyroidism or a patient who comes in pregnancy. There are non-ischemic causes of heart failure. See, they are listed here. This is important, right? Patients who are on chemotherapy, patients who have arthritis, connective tissue disease, thyroid diseases, familial, arrhythmic patients, large number of patients. Now that I'm involved with cardiac MRI, large number of patients who come with myocarditis and are missed out. Peripartum cardiomyopathy, unfortunately. Stress cardiomyopathy in young, Takotsubo, of course. Substance abuse includes alcohol. So these are the aspects that we need to keep in mind. Then do a ECG, X-ray, and the blood evaluation, NT-proBNP, and a BNP. And these biomarkers are extremely important, as I said, for ruling out. Finally, BNP, which you do in the ER, need not be always, if they are positive cardiac failure related, least of causes here, right? Least of causes. Typically, patient will undergo cardioversion because you are staff nurses, you know that in the ER. Patients who have been treated for arrhythmias are the patients whose BNPs can really go high. And of course, those on chemotherapy, sometimes age, anemia. Two very big confounders are renal failure, patients with high creatinine, critically ill patients who come with a high BNP. So don't be very sort of heart failure centered. Look at a patient in total. Let me stop my presentation at this point of time. I think my time is up, and let's listen to the further presentation. I must thank you for your patient hearing, and thank you, Dr. Abra.
I think we have some time for discussion. So, Chopra sir, can you initiate the discussion? Sir, you are muted, sir.
So I think Dr. Yadav has summed up the basics of heart failure diagnosis and signs and symptoms in a very simple manner. Recognition, if you keep these basic facts in mind, recognition of heart failure is not that difficult. There would be situations where even the best of us will get confused or foxed, But by and large, 90-95% of the patients of heart failure can be diagnosed if we keep these basics in mind. Patients' breathlessness, swelling of legs, fatigue, inability to do things that they could do earlier. I think these are some of the very, very important features that one should ask for. Of course, we remember that there are other conditions, anemia, lung diseases, etc., which can also be responsible for similar symptoms. But I think these are the major issues to be kept in mind.
I agree. And from a nurse's viewpoint, they can contribute a lot because they are the eyes and ears of the clinician, and they are the first point of contact. And you get more information than maybe a busy consultant. And sometimes, like Chopra sir said, sometimes diagnosis may be missed, especially if the ejection fraction is normal. But then, like I think it's part of a team. Now it's always teamwork, and the nursing professionals can be major part of diagnosis, prognostication, and they should know what they are looking at. Dr. Shantanu, your comments, please.
Yeah, I think it's very important as Dr. Jadhav has very simplified very nicely that before a doctor comes, if the nurse, even a male or a female nurse, picks up this subtle signs, either in a casualty or also in the wards, that if a patient is getting breathlessness, these are changes. So I think they are the main gatekeepers of identifying a problem, because we have also seen many patients who may get admitted for some other problem. For example, I've seen patients of obstetrics or gynecology, they're getting operated for something, but over a period of time, they develop some breathlessness or something. As a team, these nurses you can pick them up, immediately call the doctor and try to identify the problem. And I'm sure I'm going to tell how to go about the things whenever such a problem arises. Because they are the gatekeepers of identifying the situation, so that the treatment is given to them immediately, so the complications are prevented. Yeah.
Dr. Uday, anything more to
Thank you. I think we will look forward to the further discussions on the ECGs and X-rays, unless there is specific question from the attendees. We're really glad to address that.
Okay, then we'll move on to the next part, that is diagnostic evaluation in heart failure, clinical ECG, X-ray, echo. What is EF? Introduction to cardiac MR. This is a multiple topics, and Dr. Shantanu is the president of the Indian Academy of Echocardiography, is the president of that, and has been bestowed an honorary fellowship. So that only shows by the Royal College. So that really shows his keen interest in all these aspects. Over to Dr. Shantanu.
I think a great initiative. So I'm just going to focus and tell everyone what are the important things they should know as a gatekeeper to identify the problem of heart failure. And if we can pick these things at an early stage, how we can prevent more complications at a later time. So I've shown heart, and I'm also showing the lungs together, because heart failure is a problem of both, predominantly a cardiac problem, but there is a breathlessness, and we have seen a lot of respiratory patients going to the respiratory team, but never getting a cardiac checkup. But I thought that they should also have a cardiac assessment, because many of the respiratory problems also have an underlying heart failure component, which may be a primary thing. So let me tell you that a lot of us are aware of the concept of heart attack, that is acute myocardial infarction. But this is an important work. Why heart failure has suddenly come up very strongly. And if you, this was a work in one of the important journals called Circulation, comparing acute MI, that is heart attack, with acute decompensated heart failure, a patient coming in breathlessness in an ICU. So incidence, if you see, is more or less similar. The mortality, patients dying because of these conditions are more or less similar. Patients dying after discharge in 3 months, 2 months to 3 times is higher if a patient comes in acute decompensated heart failure as compared to acute MI. The pathophysiological targets, we know that we can put a stent in a patient of acute MI, but ADHF is too complicated. I mean to say, we can have heart failure with low ejection fraction, normal ejection fraction, or ejection fraction in between. The pathophysiology is different. It changes. We have lot of trials which have proven that we can put a stent, we can have some savior. But in acute ADHF, it is growing. We are still evolving. There is guideline-directed medical management for HFrEF. In HFpEF, we have very limited treatment. The recommendations are evolving. So what I want to tell you that just try to understand that cardiology is not only heart attack. You also have a problem, which is heart failure, which is equally gruesome. So that's the reason I think HFAI, we have initiated this so that we know the importance. Now, as Dr. Jadhav was telling about what is heart failure, it is a condition in which the heart is unable to pump the blood at a rate or at a demand to commensurate with the requirements of the tissue, or it does it with an elevated load. So the pressures become high. So the best of that person is not good enough to sustain, either at rest or at whenever the patient is walking or doing some exertion. And as we know, the symptoms, the way the patient generally comes, they generally come with either fatigue, weakness, you can have breathlessness, and as Dr. Jadhav was telling, there is a status or a clinical assessment called LYH status 1, 2, 3, 4. You can have breathlessness on minimal exertion, more exertion, or patient can be breathless at rest. Generally, if you see this person, they have swelling in their feet, they will cough. The cough increases when they lie down. They become more breathless, but when they sit, they feel slightly better. They can also come out with occasional chest pain or some discomfort, and few patients can come with syncope. So these are the predominant symptoms of a heart failure with the person comes. And whenever, remember, as rightly pointed earlier, it is a clinical diagnosis, and all nurses, you are all basically a support team for the team has to make that clinical diagnosis. Because let's say we are in an OPD and there are 10 patients coming to the OPD, and if one person is having breathlessness or is breathless at rest, we have to prioritize and send that patient to the doctor immediately, and we cannot ask him to wait because it's all about saving that patient. So there are few criterias. There are major criterias, minor criterias, and as rightly said, the patient will have breathlessness. There will be distension of the neck veins. You can have crepitations if you auscultate. There will be fluid in the lungs. If the heart rate, they have heart rate which is higher, tachycardia. You can have a lot of these things which make them a major criteria and minor criteria. So remember that heart failure is a clinical diagnosis which is generally supported by ECG, biomarkers, blood tests, and then echo and X-ray, so that we come to a conclusion that this is surely a patient who is suffering from heart failure. Now, remember, Dr. Jadhav was telling about the NYHS status, which was divided class 2, class 3, class 4. And it's a very important study way back, which came almost 25 years back. So if a patient who has a severe heart failure or who has an NYHS class 4 generally dies because of heart failure. So they die because of breathlessness. So it is important to understand that we have to identify this classification and tell to our colleagues, tell to our doctors what is the severity of this functional class. And if you can pick them up, you can tell your consultant that he is having breathlessness at rest. Let's try to target or treat him immediately. I think we have done our job. But I think very important for us is also to understand that heart failure doesn't happen in one day. It is a progressive disease where the patient generally can go from asymptomatic, patient may be normal, but there is subtle change in the heart, which is called asymptomatic LV dysfunction. There is a status of compensated heart failure, progresses to decompensated heart failure, and when there's a phase when the patient will not benefit with any medical treatment, which is called refractory heart failure. And this is a problem we have been facing. If we can, by any chance, with your help, with technology, with everything, identify these patients in this asymptomatic LV dysfunction or this group, put them on right therapy, put them on guideline-directed medical management, I think we've done great. So the key is try to pick these patients. And what are these patients? These are the patients who are generally hypertensive, who are diabetic, who are obese, who have coronary artery disease, who are hypothyroid, who have some connective tissue disorders. So these are the patients who can have asymptomatic LV dysfunction. Patients of COPD who are chronic smokers. So if you can guide this patient, guide them that please get your ECG, get your echo done, get your blood test, we can put them on good treatment and prevent this progression, or at least delay this progression and have a better life. So the heart failure earlier was divided as systolic and diastolic heart failure. So why? This was a classification almost 20 years back, but I'm just keeping it to make it very simple for you. The names have changed, and I'm going to come to that. Systole is nothing but when the heart contracts, and diastole is when the heart relaxes. So it was called diastolic heart failure, systolic heart failure. And the names of this have now changed. Systolic heart failure is now called HFrEF, which is heart failure with reduced ejection fraction. Ejection fraction is the ability of the heart or the left ventricle to pump the blood, and the normal ejection fraction is around 60%. So in systolic heart failure, the ejection fraction goes below 40%, while in diastolic heart failure, the ejection fraction is normal. It is called heart failure with preserved ejection fraction, but still the patient has breathlessness. So as I said, the most common cause of systolic heart failure or HFrEF is coronary artery disease. This should be less than 40%, but you can also have HFpEF, where the patient's pumping is normal, but still he has breathlessness, and this is classically seen in patients who are hypertensive, diabetic, obese, hypothyroid. So it is mandatory that all patients of this group should get an evaluation to understand their ejection fraction or echo status. Now, this is what I was trying to tell you, is that these are the guidelines. If a patient ejection fraction normally is 60%, if the EF is less than 40%, it is called HFrEF, reduced ejection fraction. If it is more than 50%, it is called preserved ejection fraction, or this is heart failure with mildly reduced ejection fraction, which is also earlier called mid-range. It is now mildly reduced between 41 to 50%. So this is an entity because the treatment slightly changes. The prognosis is more or less similar. Now, once we identify these patients of heart failure by their symptoms and signs and understanding what is the problem, you start looking at the findings. See, you can do blood findings, you can do X-ray, and we can do ECG. The most important blood findings or blood thing which you should know is hemoglobin, anemia. What is the anemia? It is not normal hemoglobin in males should be around 13, 14 and above, and females should be around more than 12, 11.5 or more than 12. So if a patient has breathlessness and if his hemoglobin is 8, 9, he is unable to get the blood carrying oxygen. So he will be incapacitated. So we treat them we identify their iron levels, we identify their B12 levels. And if it is iron deficiency, we give them iron supplements. It improves the morbidity, or it improves the quality of life of this patient. The second important thing is also to look at thyroid, because hypothyroidism, when the TSH is high, or hyperthyroidism, when the TSH is low, these are reversible causes. If you treat them, reversible causes of heart failure. If you treat the thyroid, the patient can improve in their ejection fraction. They can have improvement in their clinical status. The third important thing is looking at the kidney function test. How do the kidney are functioning? Blood urea, creatinine, then you do eGFR and creatinine clearance. Everybody is carrying a mobile app. Mobile has these applications where once you know the creatinine levels, you can get a eGFR according to your age, and you can tell. Because if the patient has a poorer renal function, the prognosis becomes poorer. So it is very important that we also know and look at the kidney function test. Also understanding their sodium and potassium levels, because the medications which we are giving, which are basically a part of the guideline-directed medical treatment, are focusing for heart muscle modulation. They cause some changes in the potassium level. Don't forget these two important laboratory findings, laboratory tests, which are mandatory and we should know by heart. Is the first most common is NT-proBNP. NT-proBNP normal values we should know for your own lab. NT-proBNP are markedly elevated if the patient has HFrEF. They are elevated if they have HFpEF. NT-proBNP we generally do at the time of admission and also at the time of discharge, because they have basically a prognosticate value. And this is an important thing. Maybe once you go back to your hospital, just try to look what are the normal values of your lab. And troponin values are also gives you an understanding about the cardiac injury, how the muscles are injured. Any troponin values higher has a poorer prognosis. So these are few of the tests we should be aware of whenever you're treating heart failure. Now, coming to ECG, as we all know, we are doing, everybody of you are aware, you have been doing ECG. It's a 12-lead ECG. I will not be telling you how to do it, but I thought you should know that the ECG has got few nice looking waves, which are called PQRST. But remember, the important thing is it tells you about the normal cardiac cycle, where there is systole and there is diastole. And we have to be aware, we're looking at the ventricle. The heart has got atrium and ventricle, and you have left side and the right side. Why am I telling you? Because we have to also know something about the echo. So the ventricle is important, and I will not tell this anything about atria, but remember the tip of R wave. Whenever you're looking at the tip of R wave, it defines that the relaxation or the diastole is ending and the heart has started pumping. So tip of R wave indicates the diastole, and the tip or a downstream of T wave indicates the systole. So this is something about cardiac cycle. I thought as an HFAI, you should learn slightly more than what you are knowing. But the important thing is, whenever you look at ECG, I'm sure we can have some class on how to read an ECG. You should know that it tells you about the complete cardiac cycle, and the tip of R wave is the diastole, and the tip of or downstream of T wave is the systole. Now, ECG gives us a lot of idea about what is the patient's problem. So let me show you, this is an ECG. It's a 12-lead ECG. And as you can see, all the deflections are very low voltage. So if you see, the voltages are low overall. So this was a patient who came who had heart failure, but she was obese, and her TSH was almost around 8.9 or something. So she was a patient of hypothyroidism. So on ECG, we can get an idea that this is a reversible case of heart failure. We give a thyroid supplement, we treat them, and these things can be treated very well. A second ECG, this was an ECG of a patient who had a dilated heart, big heart, had ejection fraction which was low, 25%, was a case of dilated cardiomyopathy. And as you can see, this is 1, 2, 3 AVR. So these are basically the limb leads, and these are the chest leads, V1 to V6. We all put the chest leads on the chest. But as you can see, the voltage of the QRS complex here is large, but here it is smaller. So this gives you an idea that the ejection fraction must be low in this patient, and the heart rate is also slightly higher. So if this kind of ECG comes to you, you can always go talk to your consultant, show it to them. Do you think, sir, I would like to look at the echo. Can I see, is the ejection fraction low for this patient? So that's the way we try to learn and understand. A third patient, again, the patient had some LV dysfunction. And as you can see, these are irregular. This is the normal, there is an abnormal ectopic. There's a normal, there's an abnormal ectopic. There's a normal, there's an abnormal ectopic. So this is not a normal ECG. So if you start looking at this ECG, this is a marker that this patient can have is proarrhythmic. This patient has some problem. So this kind of ECG, always you should report, show it to your consultant and try to understand. I'm not going to all the details, but this is an irregular thing. This is an abnormal ectopic which is coming regularly in this patient. And last, one more ECG, patient had ejection fraction of 20%. But now this kind of ECG comes up, let me tell you, you have to call your consultants immediately, because this is a very bad ECG and this has to be treated. So don't wait. This is an emergency call. Call your consultants immediately, because this is an abnormal rhythm. The patient is just bursting with a lot of problems, and he has collapsed, or he may be collapsing anytime. So these are important. So whenever we are getting this kind of ECG, I think you should cover. Now coming to X-ray, remember X-ray chest, whenever you are doing, it is always PA view. It is not an AP view. You have to show and get an X-ray chest PA view. An X-ray shows this is the cardiac silhouette, which is called the heart, and these are the lungs. Of course, these are the wires, that means the X-ray was done when the patient was in the ICU. But as you can see, that there is the left side, this is the left side of the heart, this is the right side of the heart. And you can see the bifurcation of the trachea like this. As you can see, the left side of the heart is completely straight. And there is a heart cardiac silhouette, which is slightly bigger than normal. And this is the descending pulmonary artery. So if you start seeing some haziness, this patient has been in pulmonary edema, and there is a straightening of the left heart. I can go in details, but this is a patient who needs, if the BP is normal, needs a diuretic. Don't give a diuretic without consulting doctor, but this patient needs support, oxygen support. It must be in heart failure. Another ECG, X-ray, can you see the heart is even bigger than the previous one, and the lower side of the chest has some haziness. So this is a patient again of cardiomegaly. We label it as cardiomegaly, and must be having a dilated cardiomyopathy, or ejection fraction may be lower, and this patient must be in heart failure or pulmonary edema. And if you can see, this is a very bad X-ray, where you can hardly differentiate where is the heart starting and where is the heart ending. So this patient has cardiomegaly, but also there is obliteration of both sides of the lung, must be having some pleural effusion. I don't know what is it. So you always suggest that if you can do a right lateral X-ray also to identify. So, but this is a patient who needs an ICU admission, must be his oxygen must be lower. So this is an important thing. An X-ray should always be done. So as a technician, if you have technicians, always try to get an X-ray PA view rather than an AP view. Now, moving ahead to the echo, but I thought let me show you how does the heart look like. So as you can see, this is, I'm sure few of the nurses must have gone inside the operating room to see the heart. This is how the surgeon sees the heart. This is the LV apex, the tip of the heart. And as you can see, it is twisting. It is just twisting. So it is one of the most efficient organ in the body, in the world. And it is just twisting. So it squeezes blood. It is just like a wriggling motion, or it is just like if you want to take out water from a wet cloth. So if there is a cloth which is wet, and if you want to take out water, you will squeeze it, right? So it is squeezing like this. The day this wriggling motion is gone, the patient will have dilated cardiomyopathy. And this was identified way back in 1600 by the student of Galileo, that the heart is one of the most efficient machine in the world, which is pumping 70 times in a minute, 365 days, and it doesn't stop, and it doesn't get fatigued. And this pumping increases without any without any stress when you are exercising. It goes to 120, 130, 140 times per minute. But once this churning movement changes, the patient has heart failure. And this can be seen in the muscle. As you can see, this is one muscle. So the outer part of the muscle is moving in one direction, and the inner part is moving in the other direction. So this muscle component churns and moves, helps the blood inside the cavity to move out. So in systole, as I was talking about this systole, it is churning. It is churning, systole, diastole, systole, diastole. So this is a phenomenal machine which helps in propelling the heart. And this today we can see looking at the echo. And as you can see, there is one more thing. This is the epicardial and the endocardial. As you can see, the lower part is moving in right direction and the left upper part is moving in the other direction. So this churning is seen, and it is basically the orientation of the muscle fibers. And remember that this orientation of muscle fibers gets altered in heart failure, and we have now medications to treat them and treat them properly so that these patients have a better quality of life. So as I earlier told you that heart failure are of three types: heart failure with ejection fraction which is reduced less than 40%, which is nothing but the systolic heart failure. We have heart failure with preserved ejection fraction, which is diastolic heart failure. But remember, the incidence of HFpEF is very high now. So both the incidence is almost 50%. So you remember that we have to pick these patients at an earlier stage, and this has to be picked up. Now, I was told that I should tell you something about the ejection fraction. So this pumping, this churning, or the movement of the left ventricle is nothing but the ejection fraction. What it maintains, it tells you it is nothing but the amount of blood in the left ventricle in diastole when it relaxes minus the amount of blood in systole. So the blood moves out. This is stroke volume. In one pumping, this amount of blood comes out. But we need a fraction. So the fraction is left ventricular end diastolic volume minus end systolic volume divided by end diastolic volume into 100. So it is a fraction, and the calculations over a period of time with a lot of research, we have come to a conclusion that the ejection fraction normally is 60%. Anything, so the whole heart failure concept revolves around ejection fraction, and you should know. And remember, whenever we are telling the ejection fraction, we should always mention what is the heart rate of the patient, what is the preload, how is the how much amount of blood is coming from the lower limb, from the upper limb, and what is the contractility. Because remember, everything affects the ejection fraction of a patient. So whenever we tell a blood pressure of the patient, before that we always tell that the pulse is this, the blood pressure is this, because everything affects the ejection fraction. So let me show you a patient on an echo. And as I said, this is left atrium, this is left ventricle, this is right atrium, this is right ventricle. If you can see the left ventricle, it is hardly moving. Okay, so it is hardly moving. So this is diastole, systole, diastole, systole. So this was a patient who had systolic problem, whose contraction was less. This patient was in HFrEF, and we always have an ECG below. Then this is the next patient where you can see the pumping was normal, but the patient had, let me play. So this patient had heart failure, but his pumping was normal. So this was a patient who had heart failure with preserved ejection fraction. So this patient has basically the left atrium, which was started becoming bigger because there was a lot of backflow problem. So HFpEF has a problem where the stretching, the diastole becomes problematic, and then we have lot of indices to identify. But this is an important entity, and I was trying to tell you that the left atrium is also an important thing. So in 4-chamber view, you have left atrium, left ventricle, right atrium, right ventricle. So this also enlarges in this group of patients. So this is in short about the diagnostic workup of heart failure, where whenever we start looking at the symptoms and signs, you start looking at the signs, you go for an ECG, get the biomarkers, get the blood test, do an X-ray test, and subsequently you do an echo. We identify the things. And I was told that I will like to have 1 or 2 questions. So can I put the questions now, sir?
Sure.
Yeah.
Briefly.
Yeah, 2. So as I asked you, when is the end diastole on an ECG? So how do I answer? So end diastole on an ECG is important. It is nothing but the tip of R wave. So whenever you look at the PQRST, it is the tip of R wave. The second is NT-proBNP, important biomarker, gets secreted from where? Is it the right atrium, left ventricle, lungs, or liver? It always comes from the ventricles. Remember, NT-proBNP is a marker of heart failure, gets elevated. Third, as I said, HFrEF is an important entity. Ejection fraction, is it more than 50%, less than 40, or this? So the answer is it should be less than 40%. So you should know all this entity. And there is something called PND. What is the PND? PND is basically paroxysmal nocturnal dyspnea. So I think let me thank. If you have any questions, we'll be happy to answer them.
Dr. Shantanu, can I ask you a question?
Please, sir.
Do you think that in the near future or the present, the nurses should learn at least basics of echo, because now the AI and handheld devices are coming in a big way. So many of the barriers would be broken. So should all nurses be familiar with ECG and be able to identify basics of echo, in the sense something like LV function, some pericardial effusions, some regurgitations. So as the president of the Indian Academy of Echocardiography, what is your stand on that?
I think we already have sonographers predominantly in the south part of the country coming up to the center. But I'm really excited to tell that the word sonographer should be replaced with physiologist. So if we can make nurse physiologists and we can train them at least the basic of echo, that will be great. A concept which I was thinking of. The answer is yes. They should know something about ECG, about echo. The answer is yes.
There are many questions, Dr. Abraham, in the chat box. Maybe you have to
Yeah,
answer.
so I think one question is how thyroid issues related to cardiac failure. Yeah, so I think as I said, can I take it? Can I answer?
Yeah, please.
Thyroid issues are basically hypothyroid when the TSH is high or hyperthyroid when the TSH gets low. Both of them cause reversible heart failure. If you treat them properly, they can be the heart failure comes back. But if you don't treat them, then they can go for irreversible heart failure. So I think all patients of heart failure should be looked for reversibility, and thyroid issues is one of the most important thing.
Then there's a question on diastolic and systolic heart failure. You
That has
mentioned
been
that.
explained.
Yeah.
That has been explained.
And percentage of incidence of or heart failure among obese people.
I think it's pretty. I mean, okay. So how should I? Symptomatic heart failure is, I think, less. But then I gave you a concept of asymptomatic LV dysfunction. So if they will not come to you if you don't pick them up. So I think all patients of overweight or obese should be screened for heart. Am I correct, sir? What do you think?
I agree. I totally agree. And most important question is life expectancy after heart failure, because that has to be in the West and India. Hari, I think, is currently not available. So from trying about what is the life expectancy after heart failure in India?
I think we have learned from Indian registries that heart failure life expectancy actually depends upon how well we treat our patients. In the Trivandrum heart failure study and the Kerala heart failure registry, it was significantly bad. I think it was something like nearly 50% mortality at 5 years. But in the same analysis, those patients who received better treatment or a full guideline directed treatment, their prognosis was significantly better. Having said that, I think the care of heart failure in our country is improving steadily. And the prescriptions that we see now, they are not ideal, but they are much better than what they used to be 10 years back.
Yeah.
Yeah, I totally agree. Actually, from our heart failure clinics experience, it's basically nurse driven, as I said. Initially, actually, when we started, this in tier 2, tier 3 south towns and cities, not exactly in the corporates or the metros. We found that like initially the all four drugs were only 3%, but with proper nudging and training the nurses, now it has within 2 months it has become around 20%. So about six-fold increase in 4-drug GDMT. Well, that is where the nurses is the key. And Dr. Uday, there's another question for you. What is the relation with kidney in the heart failure? So how do you look at that?
Right. So kidney disease has two aspects to it. One is that they do have a associated coronary artery disease, which goes unchecked at times. Second is, as we all know, the hypertension response in patients with chronic kidney disease is really an issue. They get a significant level of high blood pressure, more than moderate to severe. It's difficult to control hypertension in viewpoint of restriction of the medicines that we can use. So hypertension related heart failure with preserved ejection fraction is extremely common. These patients have coronary artery disease at times, so they have a heart failure with reduced ejection fraction too. Then they have anemia of heart failure, so anemia of chronic kidney disease. So actually that both triggers and aggravates the existent heart failure. So chronic kidney disease has multiple mechanisms, both erythropoietin related and unrelated, blood pressure, myocardial function, the relaxation function of the myocardium, and of course the hemodynamic load these patients suffer because of increased fluid. So there is a very close connect between kidney disease and heart failure. Sometimes it's difficult to make out always because we start blaming the shortness of breath to everything else that kidney patients have, including fluid load, but actually they have an impaired cardiac function. So it's very vital that not only they be studied in the beginning, but they be monitored also for various symptoms and signs of heart failure.
So there is one question from the YouTube. We have nearly 600 people watching live the YouTube also.
700.
Okay, so this is Dr. Shantanu. So, like the question is very basic. How can have heart failure with normal heart function?
Yeah, so I think, I mean, I will give you a corollary that if you pinch the skin of an elderly person, let's say who is 80 years old, if you pinch it, his skin goes very slowly back. Versus us, if you pinch a younger guy, it becomes normal. So what happens if you have problems like diabetes, hypertension, obesity, or something? This relaxation problem gets aggravated, and he or she presents with the relaxation problem of the heart. So the diastole stretch becomes problematic. So that's why it was earlier called diastolic heart failure, but now because there is a problem, the pumping is normal, the forward flow is looks okay, so it is called the ejection fraction may be preserved, but the relaxation is the problem. That's why it is called heart failure with preserved ejection fraction. But if you don't treat them well, they can progress and can have their ejection fraction going down. So that's the reason, a broad explanation of this.
And another question in a similar vein again to Dr. Shantanu, because what is the criteria for heart failure same for pediatric population? And that is the basic question. Or the ejection
so-
fractions are different in
No,
pediatrics.
no, the heart failure classification on basis of EF is there, irrespective of the reason of the age. The only difference in pediatric population, they have more of congenital heart disease. So if you have a TAPVC, if you have other things, if the heart LV goes down or the dominant ventricle goes down, then but the treatment changes. The treatment may not be the same for them. Yeah.
So again, another question, why is X-ray taken in PA view, not in AP view?
That's a very important question. I think it's about looking. I mean, okay, there's a lot of physics involved. So it is related to your spine first, and it is also related to the. So if you go back and take an X-ray of the lateral view, take X-ray chest lateral view, and this will help you. And it is about the orientation of the lungs and the heart in the axis. So what you want to achieve, you have to look at both the lungs and the heart. So the positioning of the heart and the lung are better seen in the PA view, because in AP view the spine comes up. That is the biggest problem. Am I correct? You want to add anything?
For a few seconds, so can you repeat that?
Sorry?
We lost you. The connection was little ovary. So can you repeat the last statement?
So in AP view, the spine comes in forward. So you're looking at the spine, but in PA view, we are looking at the orientation of the lungs and the heart. And this can be best explained if you take the X-ray of a patient from the lateral view, and it helps. Dr. Jadhav, you want to add anything?
Yeah, I mean, the lung vasculature is best seen on the PA view. If you take a AP view, that's basically straightening out the ribs and
Yes.
getting the vertebrae prominent, the spine prominent. So that's not the view you need in heart failure. You need just a PA view. And if there is any doubt about collection of fluid anywhere, then just take a lateral view, right? So you can see the angle, the costophrenic angle very well in the lateral view. So that's it. No AP views for this.
Yeah.
And this is to
So
Dr. Jadhav again.
Yeah.
Hypertension. So how often patients at risk of heart failure need to undergo investigations, like a young hypertensive on treatment? So
I
how
think it should
often?
be
Yeah.
mandatory that their echocardiography should be done at least once in a year, because then you know how is their overall function in terms of both systole and diastole. And also, we need to keep this in mind that when hypertensives come in ER with a very severe hypertension, actually they have a HFpEF-like presentation. It's the diastole that suffers first. So sometimes just because their systolic function is okay, they are labeled as something else, but that's not true. So every year, those with a grade of moderate to severe hypertension should get a echo done. And that's straightforward, cost effective in this country.
So two questions were, I'll just answer that. Ischemic heart disease is the commonest cause of heart failure in our country. It's a trial led by Dr. V.K. Chopra. It's about 70 to 80. Vedanta registry, sir, 70 to 80% had ischemic heart disease, if I remember correct. Sir, your opinion about that?
So, I mean, times have changed. 50 years back, when we were medical students, if we saw somebody less than the age of 50 with ischemic heart disease, the whole batch used to be called, "Come and see a young person." Nowadays, any number of people with less than the age of 30 are getting myocardial infarction. And with the better availability of CCUs and treatments, they are surviving for longer periods of time. And later on, they land up with heart failure. So certainly the incidence of heart failure in our country owes its preponderance to ischemic heart disease. Then on top of that, we are diabetes capital of the world. And again, that is something which is closely associated with coronary artery disease. So yes, incidence is extremely high in South Asia and in Southeast Asia also.
Dr.
You know,
Shantanu,
Imran, I think we can answer the other questions online because Dr. Shastri is waiting. So I think we should get on to the next.
okay, so
And the
we'll have
questions
them
which are posted, we can answer them online.
done. So because we have time, this is supposed to be
Okay.
2-hour session. So
Okay, fine.
I'm answering
Doctor,
the questions by typing on them.
Yeah.
Can I do
yeah,
that?
we can do
Yeah.
that. We can do
Yeah.
that.
If
So
there's anything important universally, maybe you can answer that.
yeah, so we'll Dr. Shastri is like pulmonary is very senior heart failure specialist, especially interested in pulmonary artery hypertension. He must be the greatest authority of pulmonary artery hypertension in our country. And he's going to have a case study of a typical dilated cardiomyopathy, just case study and his pearls of wisdom. Over to you, Dr. Shastri, sir.
Am I audible?
Yes.
Dr. Kamal? Yeah. Thank you very much for using superlatives. Very senior cardiologist, you made me feel older. And also greatest authority. Thank you so much for that. The assignment given to me is case of dilated cardiomyopathy. I'm going to present a case. Let us see how it goes. My patient is GS, a 70-year-old female. She was first seen in the month of June in 2024. That is about approximately 1.5 years back. She has been a known hypertensive ever since she is 48 years. Progressive exertional breathlessness, class 2, since 1 year. And at that time, she had no paroxysmal nocturnal dyspnea. Presently, she is in functional class 2. She has no angina, edema of feet, syncope. She has no history of diabetes, thyroid disease, history of any ischemic heart disease at any time, including angina or acute coronary event. She has no comorbidities, especially like chronic kidney disease or COPD, that chronic lung disease. At presentation, as pulse rate was 86 per minute, blood pressure was 140 by 90 millimeters. JVP was not elevated, and there is no pedal edema. Cardiovascular system, unremarkable. S1 was slightly soft. S2 was normal, no murmurs. Chest examination was unremarkable. Initial lab evaluation showed hemoglobin slightly anemic, 11.6. Total count, other blood works are normal, including renal functions. NT-proBNP was elevated as 986. ECG showed normal sinus rhythm, QRS duration of 153 milliseconds. 2D echo showed global hypokinesia of LV with moderate LV systolic dysfunction. As you can see, this is the electrocardiogram. You see the positive QRS in 1 AVL, negative QRS in V1, and again a positive QRS in V5. The QRS duration, you can count it, but the computerized ECG gives a QRS duration of 153 milliseconds. Now, this patient 2D echocardiogram, there were frequent ectopics at the time. There is a global hypokinesia. Ejection fraction was reported as 37%, and mild MR, RV systolic pressure was 35 millimeters. RV function was normal. She underwent a coronary angiogram. The coronary angiogram showed, you can see I'm not showing everything, but this is the left main, this is the left antedescending artery and circumflex. There is suspicious lesion here at the ostium and some narrowing here. We're not very sure whether it is important or not, but given the history of suggestion of heart failure as well as breathlessness, which can be angina equivalent, we want to know whether it is really important or not. Then this is unfortunately, I don't have somehow I could not trace the echocardiogram report. Fortunately, I could get the cardiac MRI. Cardiac MRI showing global hypokinesia. Ejection fraction was reported as somewhere 32%. And there's nothing else to suggest any infiltrative, infective pathology or inflammatory disease. There's nothing to suggest myocarditis or amyloidosis or sarcoidosis. There's not much of there's not much of gadolinium enhancement or any scar. She was advised angiogram followed by CRT device. Angiogram, especially angiogram, as I have shown that, and we want to do FFR also. She was advised torsemide, spironolactone, carvedilol, sacubitril valsartan, dapagliflozin, atorvastatin, aspirin. This is pretty standard treatment. I briefly heard the previous speakers talking about GDMT, the 4 pillars. You can see spironolactone, beta blocker, ARNI, SGLT inhibitor, torsemide to decrease her pulmonary congestion symptoms, atorvastatin, aspirin in view of her erythematous lesions, which are probably important, which have to be understood whether it is important or not by doing FFR. Following these investigations, she has advised FFR to assess the ischemia and CRT device. CRT P or D at the end of the presentation I will discuss. But patient went away for some social reasons and did not come for follow-up. After 6 months, in the month of March, 17th March, she had an episode of pulmonary edema. She was hospitalized in some other hospital and she was stabilized and she came back to us. The need for FFR and if needed revascularization followed by CRT was emphasized. And again, the same picture here, the LAD lesion, we have done FFR and the baseline is 0.92, adenosine 0.89, Nicoran 0.89. People who know this will understand this lesion is not hemodynamically significant. So she is not going to get benefited either from angioplasty or bypass surgery. And then following that, she was given option of CRT. We thought CRT-P is enough, but family wanted CRT-D. They didn't want to take any chance. She underwent biotonic CRT-D placement on 20th March 25. This is the CRT-D. You can see the pulse generator. And you can see the 3 leads in the subclavian vein, one in the right atrium, one is in the ventricular ICD lead in the right ventricle mid-septum. And you can see the left ventricular lead or coronary sinus lead going into the coronary sinus. You can see here, this is the right atrial lead. This is the coronary sinus lead. This is the ICD lead in the right ventricle. And followed pre-procedure, the ECG was still showing left bundle branch block with LBB morphology. Immediately after the procedure, you can see the negative waves in the lead one. Basically, it means that you have done the person who implanted ICD, CRTD did a good job because the axis has totally changed. Here you see, this is the axis which is upward in lead 1, AVL. Here you see it is down. That means the vector is coming from the left side. And immediately after procedure, of course, the LV suddenly doesn't change. There is still moderate LV systolic dysfunction. And she was sent home on, again, the GDMT, including all the drugs which I have mentioned in the past. And in the month of May, there is clinically improvement. She is functional class 2 symptoms have improved. QRST has come to 121 milliseconds. Then subsequently by 9th October, her echocardiogram showed a near normal LV function about 54%. RV function is normal. She is in function class 1. This is the echocardiogram, which was showing the good LV function. This is the parasternal long axis, left ventricle, aorta, and LA. You can see the good contractility of the left ventricle. This is the apical four-chamber view. Again, the endocardium can be seen very clearly, and there is a good LV function. This is the M mode. Here you can see good contractility of the IVS and the posterior wall. The latest QRS ECG done on 9th October shows a QRS duration of 104 milliseconds, and that correlates with the improvement in ejection fraction and functional class. So, in this patient with dilated cardiomyopathy with LBBB, CRT has changed her course dramatically, her symptoms dramatically. Her functional class improved to class 1. There is no pulmonary edema episodes. As you can see, QRS duration decreased from 153 to 104. Ejection fraction improved. And though she has improved, the important thing, we did not stop and we are not going to stop sacubitril, valsartan, carvedilol, and dapagliflozin. Of course, one can stop diuretics. So, few slides about dilated cardiomyopathy. It's a condition where the ventricles are dilated and have decreased left ventricular systolic function. It is characterized by symptoms and signs of left and right heart failure. It may be due to genetic, post-infective, infiltrative, inflammatory, and other causes. We rule out ischemic heart disease. That's when we call dilated cardiomyopathy. Investigations to rule out ischemic heart disease and diagnose and assess the prognosis and severity of the disease. These include ECG, echocardiogram, chest X-ray, MRI. And as I mentioned, we have to rule out ischemic heart disease. The blood tests include CBP, ejection, the ESR, renal function tests, urea, creatinine, electrolytes, including calcium, we have to see. NT-proBNP, it gives a diagnostic and as well as the prognostic indicator and the severity of the elevation. Thyroid function should be tested and it should be done. Test should be done routinely. Other case-based tests may be done. In younger patients, rule out granulomatous myocarditis as a rule using 18 FDG PET-CT and cardiac MRI. MRI also rules out infiltrative disease like amyloidosis and myocarditis. The guideline treatment, directed medical treatment includes ARNI, beta blockers, SGLT2 inhibitors, spironolactone. Nowadays, we are talking about Versigua, ivabradine, digitoxin, but they are not in the guidelines. But in a individual patient, one may start them based on the clinical condition. Diuretics do not alter the natural history in the sense they don't prolong the life. They, of course, definitely improve the quality of life, and they are given as required depending on the fluid condition. Of course, we emphasize salt restriction, exercise rehabilitation, vaccinations, and close monitoring. In patients with wide QRS, especially LBBB, CRT is indicated if the left bundle branch block is there and QRS duration is more than 150 milliseconds, as in our patients. 130 to 140, 140 to 150 is a borderline indication. In patients with less than 30% ICD is indicated to prevent sudden cardiac death. And in patients where they are not improving, in spite of optimal therapy, left ventricular assist device or heart transplantation should be considered. Thank you very much. Hello?
Well, thank you very much, sir. That was short, sweet, and to the point. So, any question from the panelist and Dr. Shantanu? Any questions, any discussion points with Dr. Shastri?
You're muted, Shantanu.
Yeah, I think great case. I think we showed how optimal, I mean, identification of the condition, and if we treat them properly and the follow-up is important. I think for the nurses, it's nice that you emphasize the concept of dilated cardiomyopathy. Again, this was a case of heart failure with reduced ejection fraction, and how CRTD is one of the modes to treat them, adding to guideline-directed medical therapy.
So there was one question which I thought Dr. Shantanu should answer. One of the audience requested him to explain preload and afterload once again. So
yeah, I
can you
think
do that?
so. As the word tells, preload means Pre is before the heart. So whatever the supply we are getting to the heart is the blood coming from the venous circulation, from the lower limb, upper limb is load. And this flow of blood has some force. So we have lot of maneuvers, the leg raising exercise and everything where we can change the preload. And afterload is nothing but the resistance which the heart, which the left ventricle gets from the forward circulation. So resistance is the terminology which is after the heart, which is the load which the heart, which is it's called afterload. So preload and afterload concept should be understood because it changes the way the heart performs. And we have a lot of maneuvers in clinical practice which can change the dynamics inside the heart, because there are also valves. There are 4 valves which gets affected. So a preload and afterload heart rate is important thing. So let me ask and let me tell everybody that the only one condition which is load independent in heart is death. So the heart is such a magical machine which gets affected with sudden changes in the loading conditions in the heart rate. It is called the physiology of the heart. So preload and unload should be understood. I hope I could explain. I don't know.
Abraham, can I say something?
Yeah.
Yeah, I'd
Yeah.
like
Yeah. Dr. Shastri has some interesting
No,
comments.
nothing. Just to make them understand, it is a circulation. Preload is pushed from behind. Afterload is resistance against which you move. Suppose you are moving in a line, somebody is pushing from behind. There is a lot of pressure for you to move forward. Suppose there is a resistance ahead, you cannot move. So preload is pushed from behind. Afterload is resistance ahead.
Correct.
again short and sweet and to the
Nice one.
point. Okay, so we have some more time. So
Yeah, Uday, there is one question I think you should explain. What is orthopnea and paroxysmal nocturnal dyspnea? Question on YouTube.
Right. So paroxysmal nocturnal dyspnea is typically when patients go and lie down in the night, go to sleep. These are patients who have a significant level of cardiac failure. And when they go to sleep, 3 to 4 hours after they go to sleep, there is a redistribution of blood flow getting back into their lungs. So the lungs get a higher vascularity and a congestion, and therefore they wake up in the night feeling very short of breath. And the classical undergrad textbook description was that the patient would go to the window for a whiff of whiff of fresh air, and feel relieved. But now we know, of course, that that's not the necessity mechanism. The necessity mechanism is that once he adopts a standing position, the redistribution of the blood flow that's come back to the lungs, go back to the periphery, and if it's better. PND is not a good symptom. PND both signifies cardiac asthma, as the word is, and it also tells us about the severity of the heart failure. Orthopnea is a shortness of breath or a dyspnea which appears to rest. So goes in NYHA class 4. These patients, as expected, uh, are better off when they sit than when they lie down, because the redistribution of blood flow back from the lungs gets again into the peripheries and patient feels better. So both these symptoms indicate a significant severity of left-sided failure of the heart, and they are very predictable at that points of time. Unlike a chronic obstructive pulmonic disease, or what we call as a lung-related dyspnea, where similar symptoms can occur, let's say in COPD, in emphysema, but it has an unpredictable course from time to time, not a progressive course.
Right.
again, Dr. Uday, another question. Can you explain compensated and decompensated heart failure? And how does the pathophysiology influence each other or differ?
Nice question. So it goes by the physiological Frank Starling law that the recruitment of the myocardium and ability of the healthy myocardium allows a patient to remain less short of breath for quite significant duration of time. That's why often we see patients come to the hospital or ER who said they have never been breathless before. And on echo, the cardiac systolic function, let's say EF is 30 or 35, and they deny symptoms. So actually, it's not that they do not have symptoms. They do have some level of symptoms which have been overlooked. And then there is a trigger factor which has decompensated them. The decompensation factors commonly in our country or that triggers a typical heart failure episode or a worsening heart failure episodes are respiratory infections. In our country, both influenza and pneumococcal infections. That is the relevance of giving both the flu vaccine as well as the pneumococcal vaccine. Second cause are anemia when they bleed or have iron deficiency anemia and the hemoglobin oxygen carrying capacity goes down. Third is when they get in with arrhythmias like atrial fibrillation commonly in our country. And fourth is, of course, when the drug compliance has dropped and the dietary sodium intake has increased significantly. That's the time when they would decompensate and come back to the hospitals with more aggravated symptoms.
And again, there seem to be many queries about heart failure after COVID-19. So I would request Dr. Shastri, Dr. Chopra, Dr. Uday Jadhav, and Dr. Shantanu to give their opinions. Then we'll move on to Dr. Shantanu's session.
I think we'll leave that to Dr. Shastri. He's the wisest.
See, I personal take is the poor COVID is blamed for so many things. Their question about really COVID increase the myocardial infarctions I'm not sure. I'm not convinced. Really looking at my own practice, epidemiological studies, it all depends on how you do the study and report. My personal take is COVID did not really increase the heart failures condition perceptibly. But what happened? COVID did increase myocardial infarctions, especially because of thrombotic tendency in some patients. Some patients with COVID did have myocarditis, which was temporary and recovered. And probably, excuse me, probably there is the patients, there is a case report, there is a series of cases, MRI showing various abnormalities following COVID infection, but they are not really clinically relevant. Now, because of COVID, during those times, many patients could not come to the hospital, probably could not procure medication, could not have proper supervision. And because of the socio-economic condition prevailing at the time, what was actually happening in the society, many people could have skipped medicines, did not get consultation, and could have died. Other than that, personally, though some statistics may show that there is increase in myocardial infarctions, etc., I'm not sure. I don't know what others think. I don't think I'll blame COVID. COVID did cause, in my opinion, some long-standing pulmonary fibrosis. Some patients probably they are predisposed or whatever inadequately treated. But other than that, in terms of heart failure or even heart attacks, I am not convinced COVID was responsible. What do you think, sir?
Dr. Shastri, I think I totally agree with you. Except, I mean, there's one thing that I would like to say. It caused a lot of inflammation. And we know that strong inflammation can be one of the triggers for a plaque rupture. I don't know whether there's any evidence for it, but this is another theory which has been around, that plaque ruptures, any strong inflammation can cause that.
Yeah. Even vaccines are blamed. I don't think vaccines really increase
I
the
think that
incidence.
was unnecessary.
What
Lot of
Shantanu and
questions-
Jadhav, probably they are more aware of the recent publications and up to date.
Yeah. Lot of questions on pediatric heart failure, Dr. Abraham, if you can
Yeah, we
address those.
discussed that. Is the EF
Or is there a session on pediatric heart failure separately?
that would come later because we'll
Okay,
have
so
specialty or this is a general teaser into the world of heart failure. Then
Okay,
we
so-
will have subsequently further.
those questions will come later.
Yeah.
15%.
Yes. So there are lots of questions, very deep questions. Digoxin heart failure making a comeback. The valve stenosis treatment is not only saved, but you have to open up the valve either by surgical or percutaneously. So I think now that the rest of the questions we'll answer directly. So I invite Dr. Shantanu to have the recap and few questions.
So I think I already showed the questions earlier, but do you want me to play it again, sir?
No need. So you can have a recap and what do you think and how should this program go forward? Your take.
I think initially Dr. Uday Jadhav told about the concept of heart failure very nicely. I think he made us all understand that heart failure is an entity, and it has to be picked up well, and if properly identified, the nurses can and help the clinicians, and it is a basically team effort which goes in managing heart failure. And I think, as I showed, that the diagnostic assessment revolves around looking at the symptoms, signs, because heart failure is a clinical diagnosis, and we have to get help of X-ray, ECG, biomarkers, blood values, and also echo. But I think looking at the excitement and the number of questions from the audience, I am overwhelmed, and I think everybody will agree that there is a lot of interest amongst them. And I think it's a great effort we are doing. I think we have to expand it on a bigger way.
Yeah, one last question there, because I thought very relevant question, I think, to Dr. Shantanu again. There's a question, what exactly is a heart murmur? I think that is very relevant because we are talking about we went to the questions in the chat box include patient with paralysis, digoxin, tachycardia, cardiomyopathy. But this question is very important. What exactly is a heart?
Yeah, so the heart has got 4 valves, and valves are basically structures which allow the blood to flow in a forward flow. So whenever there is either a constriction where the valve goes smaller, or if there is a leakage, it produces sound. And this sound basically can be perceived by human ears with the help of a stethoscope. And whenever we perceive this flow, and you can also have this flow whenever there is a septal defect or there is a hole in the heart. And this perception of sound of the flow inside the heart is called murmur. And harsher the murmur, it generally correlates with the severity of the problem. And this murmurs can be systolic murmur or diastolic murmur, depending upon the valve and depending upon the type of lesion. So whenever we generally hear a murmur by stethoscope, the next movement is we have to go for an echocardiography to confirm it and try to understand.
I think that is wonderful. And I think with Dr. Chopra's and Dr. Uday Jadhav's and Shastri sir's and Shantanu's permission, we'll close this session.
Yeah, I have one comment to make. See, this is for all our attendees. Knowledge is a bilateral phenomena. There is something that you learn from lectures, and there is some knowledge that you imbibe by your own efforts. So while we try to give you knowledge about heart failure and its various aspects, those of you who are truly interested in heart failure, I would urge you to start reading some of the basic aspects. What is heart failure? Because that basic knowledge which comes from reading cannot be entirely duplicated in lectures. Lectures are time bound, they are short presentations. So I would really urge you, those of you who are interested in heart failure, to learn at least the basics of it. And then these lectures or these discussions will make a much more meaningful sense. Dr. Shastri.
Sir, because now you are steering the whole thing, whether or not any university or government recognizes, you people start a heart failure certification course for the nurses with a complete curriculum designed for 6 months or 1 year or whatever you think appropriate, with all the aspects very seriously, rigorously, and let them write exams, take the certificate. The certificate may be helpful to them. And I think later on over a period of years, the universities may recognize it.
And considering that heart failure is likely to become the commonest cause of admissions for cardiac patients, as it is in the West, so greater knowledge about these and greater knowledge about heart failure for our nurses is going to help them in their careers also, if not immediately, but in very near future.
Now, with the certificate is there, they'll have more job opportunities.
Yes. So I think for that, reading is important. Please acquire more and more knowledge by reading. Abraham.
Yeah, Dr. Uday, any words?
Thank you. Thank you very much. I think everything is very well said. A quick comment is that, the nurses, when the echocardiography is done, no, they should listen to the Doppler sounds and they would know if they put a stetho, you will hear that murmur. It's a very good way of those who are not putting stethos on the chest can still, when they stand by the side of the bed, look at the echo when the volume is on, the sounds and that help. Thank you very much. This has been a fascinating session. Abraham and Shantanu and Dr. Vijay Chopra sir, Dr. Shastri sir, fantastic. And I think we'll just look forward to the next sessions. Good night.
So thank you very much. We close the session. Looking forward for all your participation in the next upcoming 2 sessions. And this will be available on YouTube as well as on our site. So you can go back, listen again, ask questions again, write to us. We'll try to answer as much as possible. So thank you very much for participating. Good night.
Thank you. Bye-bye.
Good night.